surgery, trauma and critical care, and academic. These are the 4 sections.
Okay. Right. Sanjay, do you want to any comments on the case?
Yeah. Shall I give the comments?
Yeah. I'm happy.
Sorry, guys, I joined late. Can you just tell me briefly what was the case so that I can enjoy the conversation?
Right. So similar scenario to yesterday, a 60-year-old lady presenting in A&E with hypotension, abdominal tenderness, diffuse tenderness, and guarding in the abdomen. Sure. So started off with, again, the same, the bloods, lactates about 4, and the blood showed white cell count CRP raised. He made a diagnosis of possible diverticulitis. We couldn't get a CT scan done. Again, similar scenario, started some inotropes, didn't get the CT scan done. So went to theater, midline incision, exploratory laparotomy, found purulent peritonitis arising from a perforation in the sigmoid. And then we discussed that the plan was to do Hartmann's. And then we had a few questions on role of laparoscopy in diverticulitis, the risk of cancer in complicated diverticulitis. And yeah, that's about it. So
yeah, Varun did very well actually. He touched most of the things, if not all. So, but I just thought for the polishing final, for the final preparation of the exam, whether we can be more sort of systematic, saying just starting with the like a focused history, touching and include the like as you mentioned later on, the length of the pain, how long the pain was there, was it colicky or inflammatory, colicky or constant pain. We can say like a mechanical pain, colicky pain, or inflammatory pain, and then try to find out the past history, any previous investigations, say all these in the same go, initially. Then go for examination. Main idea is to know whether the patient has got local or generalized peritonitis. As you mentioned, Varun, that we'll check the loin and groin. I just wonder,
yes, he mentioned.
Do you have to mention about PR, or would you do a PR at that point, or leave it because patient is unstable? So possibly we can leave that point, but we need to mention about PR before making a final decision about when we are taking the patient to theater.
Yeah, fair enough.
So if we decide that as along the line we are deciding that now the patient is unstable to go for scan, so patient will need to go to theater, then we need to definitely do a PR before I take the patient to theater. We need to mention that. One thing, yeah, he did very well. Rest of the things, it's just a couple of queries from my point is that patient is unstable, so we can't take the patient for scan. Should I do a CT? Should I do a portable chest X-ray to make to at a slightly earlier stage to see if there's a free gash on the diaphragm, because that will help us to make a little more collaborative information to decide about the laparotomy. Yeah.
I feel like that's a valid point. We can't do it because portable chest X-ray is not going to do any harm to this patient. Yes, of course, yes. The issue is chest X-ray and abdominal X-ray definitely should be helpful because that is not going to change. That's a valid point. And regarding the physical history and the examination, I think I missed rectal examination. Yes, that is a valid point again. Regarding the history, the reason why I took the history bit later is as this patient is unstable, I can't go and ask for the history at the first instant. My first aim will be the resuscitation and the keeping the patient's vital stable than the history. So that's the reason I came to the history. And also, if it is a 5-minute scenario, we can just we can't go in depth like where exactly is the pain, like all the details. Just give a short phrases for the history. Like,
so what should you tell in the exam? Like we'll ask.
So I think Sanjay, to answer that question is, I think one, Varun, like we've mentioned before, I think you need to say when you start off with history, just say I would like to have a full history of the presenting illness, or like the candidate say with Socrates, I would like to have more information in the form of Socrates or history of presenting illness.
Yeah.
But so you have to say that But like you mentioned, it's completely right. In this scenario with the patient unstable, you're more worried about the abdomen. My concern is that this patient looks like someone who needs an emergency laparotomy. And so at that point, I think we can do that. So rather than going for each detailed history, you're just conveying to the examiner that yes, history is important for you, but in this scenario, that because of the emergency, that, unfortunately, yes, with this examination,
You have to verbalize the thing, isn't it?
Yes,
I
yes,
agree.
it's just about how you express yourself. It's about how much importance, like I said, you have to at that point of time say history, how much importance, examination, how much importance, or CT scan, how much importance, and you need to express yourself that you're thinking about the history. But right now, examination findings are enough to say, and with the patient blood pressure dropping despite inotropes, I'm sure this patient needs a surgery, so that is important. And yeah, continue, Sanjay.
So I get slightly confused. The patient had initial resuscitation fluid with antibiotic like sepsis 6 protocol. And if how long do we give? We give like a 20 ml per hour fluid or 30 ml per hour fluid, per kg per hour fluid. Then see if the blood pressure stabilizes. If the blood pressure drops after that, that will be indication that patient not stable, patient cannot go to scan.
Yes, I think it's fair to say after 2 liters of fluid resuscitation and after starting inotropes, the blood pressure is not stable. It's clear cut to say that,
okay, patient is not stable.
Yeah, again, it's not the decision that's important. Again, it's how you express yourself. So Varun, at that point, when I say, the anesthetist is asking what's the plan now, despite inotropes, the blood pressure is between 80 and 90. So again, I think it's the way you express in terms of, yes, ideally in this scenario, I would like to have more information with the CT scan. And like Sanjay says, of course, you can say maybe at this point, I may consider just an abdomen and chest X-ray to look for gas under the diaphragm. That gives me enough evidence to proceed for an exploration. So, but if the anesthetists are not able to stabilize this patient, then I think it is part of resuscitation that she will require a laparotomy. It may mean that I have to consider all the options possible. If I had a CT, it may indicate that whether it's only inflammation or a tumor and where the location of the perforation is. But I will have to back my clinical skills and judgment on the table to assess that and treat it as the best possible way. So I think again, it's just the expression and the communication of.
For the CT, usually they don't agree for the CT chest, which would be helpful in these scenarios if there's a malignancy and a metastatic. But what do we ask, say, in the exam? So we'll do the CT pelvis and a chest X-ray, or what do we say?
In this emergency scenario, I don't think a CT chest is warranted.
Okay.
So
if you
and even with the urine output, with decreased urine output, I don't think they can give you a contrast. With in spite of all this resuscitation, a contrast will not be advised, and the radiologist will come up and say that, oh, the contrast cannot be given, so you can't have a perfect CT scan, but we can give you some vague idea what is happening in the tummy. So with all these things, the first question is this patient fit enough to get transferred for a CT? That's it.
Yeah, that's fair enough. So you asked about that, and then we decided.
Yes, your comments.
So let me just make the points I note down. So one, I think, is Socrates to mention in the history, just to at least cover that point and say that you concentrated on that. I think you started off well with the ATLS protocols and making sure the patient is stable. You went early to examination. You did mention history, which I think is fine in an emergency scenario. And of course, in terms of expressing, even when, say, asked about surgery, I think in this scenario, it is, I feel I would say, I don't think there is any role for laparoscopy in this situation. I would like to go straight for an exploration laparoscopy.
Okay.
So it conveys to the examiner that you've thought about laparoscopy.
Okay.
Because if it's a slightly more subtle case, if it's just, just tenderness, CT showing this, that, it's just better to make it a habit to say it. You can say, in my experience, I would just go for an exploration and not for laparoscopy. So then, even if the examiner doesn't ask you if there's a role for laparoscopy, then at least he knows you've thought about it.
So, like in terms of surgery, think about both open and laparoscopy in emergency.
Yes. Yes.
Yes.
I think at every step and every situation, just assess
Okay.
what all the approaches can be before you fully commit. So you fully committed to a laparotomy, which is fine in this case, but there may be, it's just to express yourself to say that in this case, I'm sure there's no role for laparoscopy. I think the best situation is to do an exploration.
Yeah.
So yeah, I think all that is fine. In terms of questions, in my opinion, and Saqib, please feel free to correct me or anyone else. So role of laparoscopy in diverticulitis. First of all, of course, just to summarize, I think uncomplicated, of course, we'd manage conservatively. Stage 2, if there's an abscess, then if it's less than 3 centimeters, try and manage conservatively 48 hours. If not, then drain the abscess. The third thing is in purulent peritonitis, of course, in a more stable patient, there is a role or trials have been done for laparoscopy just to do a washout and drain in such a scenario with, say, a small sigmoid perforation. That, yes, it is definitely, the outcomes are debatable and complications are debatable, but what it does is sometimes reduce the risk of having a stoma, because if the patient does stabilize with a laparoscopy and washout, they can have a semi-elective operation, even if it is a week later or 10 days later, to have an elective resection, possibly even a lap sigmoid resection, and to have a resection anastomosis in the primary setting rather than a stoma or rather than a Hartmann's. But of course, in this scenario, definitely with that much instability, purulent peritonitis, it is safer to say Hartmann's as the first approach. But if you're asked for a role of laparoscopy, that would be my take on it. So,
regarding the 1 centimeter perforation, I think with the purulent peritonitis, like laparoscopy to start with, but definitely if we see 1 centimeter perforation with a big huge chunk of pus inside the abdomen, I think they will convert to an open for a thorough wash
yes.
rather than continuing with lap.
No, again, it's just to know. And the other important point, what I think we have to make on all these emergency scenarios, is to highlight the specialty. So I was reading in the companion series book that I read for the prep. So in this scenario, you have to say at the point of, say, surgery, a complicated diverticulitis in such a patient, 60-year-old, would be best managed by the colorectal surgeon.
Should we say this thing in emergency, like in the general surgery?
I think so, especially if you're giving an upper GI and HPB exam.
Okay.
I think you need to be careful and say it in the viva scenario, not in short case, long case, because those are your specialty cases. So you're treating it as your specialty case. But in, say, emergency scenario, because if you have emergency, say a post bile leak or something, you will say, I would manage, the HPB team would manage. So you can say in this scenario, it's a complicated diverticular perforation in a young patient. It would be best managed by the colorectal team, but on an emergency setting, if I had to manage it, I would do a Hartmann's with a midline exploration. So I think that's also an important thing to ensure you make.
Incidence of malignancy in a patient with diverticulitis, is it 3% or am I right? Or I don't know.
So I don't know the exact values, but I know that, so basically if it's complicated diverticulitis, it becomes 4 times or 7 times higher than uncomplicated diverticulitis. I don't know an exact value actually to be.
Saqib, you have to answer this question for sure.
So it's 5% risk of occult malignancy in complicated, and in uncomplicated diverticulitis.
No, 2018 reference meta-analysis says it's 1.6% in patient with acute diverticulitis who underwent.
So that's the reason why the data says that in uncomplicated diverticulitis, chances of missing cancer is less than 1%. And that's the reason why recent guidelines suggest no role of follow-up colonoscopy for simple acute diverticulitis. But
as long as CT is done.
Yeah. As long as CT scan is done, or as long as you had a clinical diagnosis of acute diverticulitis, straightforward, no role of follow-up colonoscopy if it is an acute diverticulitis, because the chances of missing an occult cancer is less than 1%. But yes, if you have a complicated diverticulitis, like diverticulitis associated with the localized perforation, they always require a colonoscopy after 6 weeks, because the risk of having an occult malignancy is around 5%, or some data also suggests more than 5%.
So
Yeah.
3 to 5%. I mentioned it as 3 to 5%. I think it's okay, not bad.
Yeah.
This is a recent discussion that we had. I mean, just a couple of things to add as well. There is no role of antibiotics in acute uncomplicated diverticulitis. There is no
Yeah.
role of colonoscopy in acute uncomplicated diverticulitis. Yes, there is a role of colonoscopy for complicated diverticulitis. Regarding the laparoscopic role, I think that yes, it's a very good answer to say that I know that there is a role of laparoscopic washout, but my practice is this. You can say like this. But yes,
Yeah.
very rarely.
Akib, I think for the purpose of exam, first thing is I can go either laparoscopically or open. The option will be the best option will be open, because laparoscopy in this patient is not good
So
enough to
Varun, for
stable.
my approach would be, for the purpose of exam, I will say one approach which I see or I practice. And I'll say that I practice this and I will give this option. Although I know that this is another option, if it is an emergency setting, I will say that I can ask somebody who can in my hospital who can do this approach, or in an elective setting, I will say patient to give an option. You can go to another doctor and see if he can offer you this elective operation. I think best way is that.
No, in an emergency, you can't say that you can't go to the other for the
Yeah,
other.
but the thing is that what I can say that in an emergency setting, my approach would be, if Sentinel has thrown this question to me, whether you will do a laparoscopic or open, I would say, although I know that there is a role of laparoscopic, but I always practice open operation, which is a standard Hartmann style sigmoid colectomy with end colostomy. Full stop.
All right. Any blunders?
Yeah.
Senthil?
No, I don't think any blunders. I think again, Varun, just try and work more on the, the expression of your
Yeah,
thoughts and the
I think,
choices,
yeah.
rather than the, the diagnosis and the numbers. That's all.
Yeah.
Can I just
Okay.
ask you, before you leave, just ask one more final clarification. So we did a laparotomy for Hartmann, for diverticulitis. We found like a purulent peritonitis, and the sigmoid is very inflamed, thick wall. So it's coming from there. Is it okay to say that we'll give a washout, drain, come out, or should we go for a Hartmann? Because
No,
most of the surgeons will go for a Hartmann's.
No, with 1 centimeter perforation and
no, without perforation. No, I'm talking slightly different, like just purulent peritonitis we found, and sigmoid is thick-walled, inflamed, looking the primary pathology there. Then most of the surgeons will do colorectal will do a sigmoid colectomy heart. So I think we can
go for colectomy. It's better to go for a colectomy rather than leaving it. Then because this patient will have a recurrent diverticulitis with a thickened sigmoid. The best option will be remove the sigmoid and put if possible, if there is no purulent, if it is less contaminated, we can do an anastomosis at the same time if you are a colorectal surgeon. But that option is not applicable here. This is an unstable patient. If it is a stable patient with a thickened sigmoid, no obvious big perforation or anything, better to go and do a sigmoid colectomy and Hartmann's plus or minus anastomosis depending on the expertise.
Yeah, you're right. You did mention about the results of laparoscopy is worse than the laparotomy, is it?
No, results of laparoscopy in terms of emergency in an unstable patient with purulent peritonitis, there is a more complications in collection in terms of post-op collections and all these things, and also
in unstable patient.
unstable.
So I mean, so they're doing a trial on this. I don't know if the results are out yet, but I think trial in the book mentions in Netherlands is basically to in similar setting of patients. So similar instability, purulent peritonitis, they're doing lap washout versus emergency Hartmann's. So that is the trial that's ongoing. I don't know, Sakib, if you have any results on it, but they're trying to do, so every 3 patients, they do 2 people, they do a lap washout, and 1 person, they do a Hartmann's. This is from very basic what I've read, and they're going to assess the outcomes in terms of obviously reoperations, complications, as well as
Senthil, I
avoiding a
had a look
stoma.
at the colorectal companion. I don't think the trial is going on, but the evidences are more for the open rather than for the lap.
Maybe. I didn't know if the results are out or not. So, because at our center here in Basingstoke, anyway, as far as possible, if there's a colorectal team on call, the colorectal surgeons do a lap washout and drain, and they observe for 48 hours with antibiotics, sepsis, assess, depending on how, like obviously, if it's a really comorbid patient, then it's different, it's Hartmann's. But otherwise, young patients, they try to do it for 48 hours and reassess, and if necessary, re-explore and do the Hartmann's, or if they stabilize and settle, then they try to do a lap sigmoid colectomy and anastomosis. So I mean, like Saqib said, I think, see, we need to consider all approaches, Varun. In the exam, if we say this is the best, and if you have an examiner sitting there who does the other approach, then you're a bit in trouble. So you can say, in my opinion, this is the safest. I would hesitate to do a sigmoid colectomy and anastomosis in this setting. But yes, the other possibilities are sigmoid, anastomose, and do a proximal diversion stoma, not an end colostomy. Okay, it's going to be easier to reverse than a Hartmann's, but of course, the pros and cons, the cons are going to be considering if obviously we need to see the pathology of this and all those things. But I think you always have to just give the pros and cons, because you never know which examiner prefers which approach.
Okay.
So it's just a matter of saying these are all the options, even if you're very sure to rule out one of them, like you say, in your opinion, or like Saqib says, laparoscopy in this case, I would not consider. But that itself is showing that you're considering that some people do it. That's all that I think you need to express. If you say, no, this role, this is the only thing that I have to do an exploration and a Hartmann's, and that is the best, then you're in a little bit of trouble depending on the examiner.
Yeah.
In my opinion, it's just have to be diplomatic.
Saqib,
yeah. Sorry?
Have you got any scenarios?
Yeah, I'll make a scenario, but I will tell you the scenario. But before that, I mean, the question was raised the exam format. So just to recap so that we are all on the same page. 1 day for clinical, 1 day for viva. In our exam, we are expecting patients as well. And the clinical day we will be split into a general surgery and a special interest surgery. And in general surgery, say for instance, you have a one long case, maybe of a big incisional hernia for 20 minutes, and then 2 short cases, maybe one thyroid or maybe one varicose vein or a breast surgery. That will comprise of your general surgery part. In special surgery interest, it will be again a 20 minutes long case, like somebody, if of my special interest, they give me a case of rectal cancer for 20 minutes, which include history, examination, investigation, formulaic plan, and 10 minutes, 2 cases. Maybe one is hemorrhoid, one may be rectal prolapse. That's it for the clinical day. Then it go and then it goes to the viva part. Viva part is again, as we have discussed a lot, it is 6 stations, 5 minutes each, among 4 fields, which will be spread across 4 fields. One is emergency, trauma, critical care. So it's means that you have 1 case for trauma, 1 case for critical care, 1 case for emergency surgery. That's fine. So that will be 1 viva table. Then and that will be 1 viva table, not 5 different rooms. 1 viva table means 2 examiner will be asking you 5 different scenarios from emergency, critical care, and emergency surgery. That's it. And you will spend on that table for 30 minutes. Right?
Yeah.
And then you have another table, which is for general surgery, anatomy, physiology, pathology, clinical scenarios, right? Clinical practice. Like in that, maybe the 5 scenario will be one is on the lipoma, liposarcoma, the management of the melanoma, or a hernia, femoral hernia, or inguinal hernia, whatever. They will composed of 5 scenarios all across the general surgery.
Okay, it is 5 or 6. I think it is
6. Yeah,
6.
Then it will be general surgery. Similarly, then another table will be of colorectal 6 scenarios. Like in my case, because it's my special interest, then it will be one is like diverticulitis.
Basically, special interest. Special interest clinical practice. That's one section.
Yeah, one table. Then the other table will be, so one table on the Viva will be for emergency, critical care, and the what else we called emergency surgery.
Trauma.
The other table will be general surgery table, and the other table will be a colorectal surgery. In your case, HPB or FRCS. And the fourth table will be split into two. One will be a special interest basic sciences, and for 15 minutes, and one is 15. The other bit is the, I think, 30 minutes.
Academic paper.
Yeah, academic Viva, academic foundation. So that's how it is. It is split in our this part. So this is all about this. Just little recap.
Yeah.
Shall we go for the next?
Yeah. Who wants to take the scenario?
I can take.
Who is the? Who is the? I said you are appearing in HPB, na?
Yes.
Okay, let's give you a scenario from a little bit of HPB. Okay, so very straightforward.
Give me 1 second.
Very common scenario.
Just
So,
a second. You want 1 second? You want 1 minute?
Okay.
I am relocating.
So Stantel,
okay, tell me.
You are doing a post-take round, and your registrar presented you a patient who had an ERCP 8 to 10 hours before, and she's 60 years old female. She had an ERCP for CBD stone last night, and she's now complaining of abdominal pain, vomiting, and your registrar has done the blood workup. The white cell count is 15, and amylase is 160. So how would you approach this patient?
Right. My concern here is if the patient has had any complication from the procedure. I would start by assessing if the patient is stable or whether she requires any resuscitation as per protocols. If the patient is stable, I would like to inquire further upon the history of the patient that led towards the ERCP. The indication, as you mentioned, was CBD stones, but I'd also like to see the report of the ERCP, specifically with relation to whether the stone was cleared in one sitting, whether there was any pus in the system, whether a stent was placed, and if there was any obvious concern of injury to the bowel, and also if the pancreatic duct was cannulated. At this point, if the patient is stable, I will have to consider some of the complications of pancreatitis of ERCP, which is one is pancreatitis, but with the amylase of 160, I am less concerned about that. I would like to immediately think about a perforation of the bowel as one of the possible complications. I would like to find out if this patient's blood pressure is stable, and if the hemoglobin is stable, then bleeding is less likely on my list. And the fourth thing would be if there is any cholangitis. So if the patient has features of sepsis, if there's tachycardia, hypotension with any fever, then I would consider cholangitis. I would look to image this patient as soon as possible, apart from starting her on fluids, analgesia, and if septic features are there, sepsis protocol, I would like to image this patient.
You are worried for the ERCP-induced perforation of the bowel. Can you tell us what are the risk factors which are involved in ERCP-induced perforation? What are the risk factors?
Yeah, the risk factors for ERCP for specifically with perforation would be if there was any previous instrumentation to the bowel, previous endoscopic intervention, if there's any peptic ulcer disease, any strictures in the bowel, any diverticular, and if the patient's had any previous surgery in the area, and severe inflammation or any of this pathology of the bowel or the ampulla, any malignancy.
Okay.
Those would be
so,
my concerns.
Are you aware of any classification system for ERCP-induced perforation?
No, I'm not aware.
Okay. Do you know what is the what is the amount of, what is the risk, what is the How much is the risk for an ERCP to give a perforation?
I think the risk is somewhere between 1 and 1.5%.
What is the most commonest complication of an ERCP that you are aware of?
Say pancreatitis, post-ERCP pancreatitis, which is about 3 to 3.5%.
Right. So yeah, so this patient has hemodynamics like that. Heart rate is 115. Blood pressure is 150 by 90. She is maintaining saturation with support of 2 liters of oxygen around 97, 98%. Abdominal examination, she's quite tender in the epigastrium. What is the next investigation you would like to do, or will it change your any management plan, these vitals and these numbers that I provided? Her LFTs are more or less are near normal. There is no marked changes in the LFTs before the procedure and after the procedure.
So I would like to proceed with a CT abdomen pelvis with contrast, if it's safely possible to do so, if the renal functions are okay. That specifically looking at the area around the duodenum retroperitoneal aspect to look for any obvious collection, free fluid, and any gas that could suggest a possible bowel perforation. With this scenario of the patient's blood pressure being stable, and in my experience with an ERCP perforation, usually it is possible that it is a contained perforation. I would keep a very low threshold to explore this patient. In case of obviously further deterioration, I will have to consider that that is a possibility, but I will try in my first attempt to try and conserve depending on what my findings are with the CT scan. Again, on the scan, I would also just look at other information regarding the bile duct, if there is any obvious dilatation, if there's any retained stone, and look for features of pancreatitis as well.
Is there any role of early endoscopy in managing the ERCP-induced bowel perforation or in specific duodenal perforation?
Yes, potentially, if it is diagnosed at the time of the ERCP, it is possible to sometimes apply clips in the area, which can try and seal off the perforation. I'm not sure if post ERCP it would. Sorry?
Time up.
Time up. It's already 1 minute up. Yeah. Nice approach, Sendil. I think it went well in terms of ERCP complication. So this scenario is ERCP complication. Picked it up early in the part. Concerns, you are right in the concerns. You are right in the stable and unstable patient. Identifying the problem. What exactly is the problem? When Sakib was asking about what could be the most commonest reason for any ERCP injury, I think he was expecting, if I'm not wrong, the expectation is diverticulum of the duodenum.
He mentioned.
I mentioned.
Yeah.
So that is the diverticulum. And regarding the complications, pancreatitis, as you said, any idea what decreases the pancreatitis complication?
Yeah, pancreatitis is more the higher risk in a
I'm
younger
asking,
patient with a normal
is there any evidence to decrease the chances of pancreatitis?
Indomethacin correctly.
Yeah, diclofenac they give. I completely do not agree with
so
that.
I think these are both are very valid questions. What is the risk for what are the reasons the people get pancreatitis? Of course, the reason is you falsely intubate the pancreatic duct is the most commonest reason, and somehow it is non-dilated CBD is associated with the more risk
higher risk
than pancreatitis. However, for a duodenal perforation, it is the dilated CBD which is at more risk. So it is other way.
Yeah.
The other risks are if you have a diverticulum. More importantly, if you have done a sphincterotomy, if you have done a sphincterotomy, or if you have dilated CBD, if you have diverticulum, dilated CBD, or sphincteroplasty, if you have performed, or if you have a sphincter of Oddi dysfunction, because then you are cannulating it again and again, and then it can cause.
So regarding the type.
And what is the classification?
It's Stafford's classification.
Yeah.
Stafford's classification, I think. 1, 2, 3, and 4. I think it's there in the Google. I think
that's fine.
Yes,
that's
stepper
something.
classification is quite easy. Basically, it goes the one being the most worst form and the fourth being the easiest form can be managed conservatively. One means that when you have a perforation along the medial and lateral wall of the duodenum, always horrible. You will get a sick patient because of this. The type 2 is about is a perforation which I think it's around the it's either in the CBD, it's in the CBD, it's around the papilla somewhere. But the type 3 is in the CBD.
Type 2 is periampullary.
Periampullary, yeah, papilla.
And type 3 is biliary tree.
CBD. And type 4 is a retroperitoneal. They all have a different approaches. The type 1 medial and lateral was horrible perforations, almost always require laparotomy. So if we know the stepper classification, we will say that I will do a choral and IV contrast CT scan and then we'll find where it is located. If it for stepper 1, I will my approach will be straightforward laparotomy. For stepper 2, periampullary, again the risk of laparotomy is more high. Stepper 3 is not the injury into the duodenum, rather than the injury into the CBD, and they are mostly managed by placement of a biliary stents. Type 4 is a retroperitoneal injury, mostly managed conservatively. So these are four classification system on the basis of which you make your management plan, and that are always different from the previous one. Yes, your question about the is there any way of endoscopy? Absolutely right answer. If the injuries are detected at the time of an ERCP, you can place a clips there. But if they are diagnosed post-operatively, almost always require an operation or
yeah, because it's dangerous to insufflate again.
yeah.
I think they put a clip as soon as they diagnose that there is an injury.
Yeah, if they diagnose, they always put some. They put more than a few clips.
Yeah. So complications. That's it. I think it's a 5-minute scenario. I don't think you will get it. Probably you may get it the short case if
Special
even
interest.
Special interest. Yeah. But still you are up to the mark. There's nothing different you can do, isn't it? And tell me if, from your perspective, if there is a type 1 duodenal perforation or duodenal injury, what do you think of? Like, how will you manage?
Yeah, so
probably the way of approach will be for you like this. I think if you get into this thing, if you're HPB, I think they'll ask you a CBD injury, a type 3 injury, or type 1 injury. I think the rest of the thing motivate you.
Yeah, I think I would say this is obviously a very challenging scenario, and the patient is unstable and she probably requires an exploratory laparotomy, during which I will assess for obvious contamination in the abdominal cavity and go on towards the duodenum and cauterize the duodenum. And then my approach would be to do an enterotomy longitudinal incision on the duodenum at the D2 and see if I can see the inner aspect and the perforation. Try and assess how far it is from the ampulla, and it would be unusual to have to do a primary repair of this. In most cases, these injuries are quite severe, have a large perforation and collection and contamination, by which time it's unlikely that I'm going to attempt a primary repair. I will have to keep my options open for diversion. One with the nasogastric tube, I might have to possibly divert the duodenum as well separately. Sometimes this can be done with a drainage into the duodenum or a Foley's balloon draining the duodenum, a separate drain outside the duodenum as well. And I'll need to carefully consider whether the ampulla whether there's any ampullary injury and whether that needs stenting or again diversion. This patient will be someone who has a prolonged protracted postoperative course, and nutrition will be one of the difficulties.
If you consider diversion, what diversion will you do?
So that's what my diversion would be, only nasogastric plus this.
So you do a duodenotomy and tube diversion. And
yeah, if I had to do pyloric exclusion, that will also be on my list of thinking whether pyloric exclusion is a possibility, depending again on the
somewhere,
stability of the
Senthil, I think somewhere I read that you need to do a gastrojejunostomy and this one as a separate and that one as a separate.
That's what, again, depends on the stability of the patient.
Yeah, that depends on the stability.
Depends on the stability. If you're able to do that, that's much better. Obviously, if you can do a pyloric exclusion, do a gastrojejunostomy, and then suture this area, leave drains and come, that is definitely better. But in an unstable scenario, usually 48 hours damage control, just divert as much as you can with drains, Foley's, balloon, and you reassess, and then you do a more definitive procedure. Again,
and
risk of pancreatitis, pancreatic. Sorry?
If it is a CBD injury, type 3?
Yeah, if it's a CBD injury type 3, again, it becomes a very challenging scenario to manage this. I think if it is obviously, again, open duodenotomy, ampulla, and if you can do a repair of the ampulla, again, very unlikely in an unstable patient. But if not, the diversion has to be, you have to try and stent the CBD, and then you'll have to do biliary diversion as well.
Type 3, you are talking about the type 3. What type 3? I mean, on the Ercp you have found good done type 3.
Yeah, type 3 Ercp.
And you are classifying on what classification system these types?
Staffers, isn't it? This is what is I'm talking about Staffers.
The same one he's talking about.
Okay.
Yeah.
All right.
So I think for CBD injuries, generally the diagnosis is also very difficult to establish, to be honest.
Yeah.
Right. But more importantly, they are diagnosed at the time of an ERCP mostly, because when you give a contrast and it is extravasating out of the duct, then you can find out CBD injury and you can place straight away the stent. That is what all required at the time.
Yeah, I mean, I've never seen the ERCP CBD injuries. I've seen perhaps. My only experience in trauma in this area is you get trauma that can be bad enough to cause complete D2 ampulla injury. Same that requires Whipple's.
No, just for the purpose of examination, nothing more.
No, and the last answer for the purpose of examination, last answer is sometimes that you do require a Whipple's for this rare injury that you need to do, if at all. Eventually, if the patient's
alive. But about the injuries of the duodenum, what my concept is, because I have a background of a lot of trauma in the past, so I think that what I read through the trauma as well, the how to manage the complex duodenal injuries, whether they are blunt or the iatrogenic or penetrating. I think it yes, as Senthil has told that it's more mainly depend upon the patient's stability. But if you have two patients who are very stable and you have a luxury to perform a long operation, then the factors that will define your repair will be based upon the extent of an injury. Sometimes, like in setting up a trauma, this duodenal area complex is a very you can say very much important and very much sensitive area, because there are a lot of complex organs around it. So if that is the case, you are always expect that the extent of injury may be much more than what you expect pre-operatively. For a smaller duodenal injuries, yes, you can do primary repair and just come away, get away from the operation.
Shall we go to the next video?
Sorry, the one thing which I wanted to explain about if the duodenal injuries are very much extensive, whether they are iatrogenic or straightforward, the option of bypasses that you have mentioned is there, which is gastric exclusion with or without gastrojudge. If you are not making a gastrojudge, you can give a jejunostomy as well. And some people also do biliary diversion as well by putting in a tube. And then in the post-operative phase, they give somatostatin as well to decrease the pancreatic secretion as well. So that's how you can manage the complex extended duodenal injuries.
Yeah, the other rare options are, if not in between primary repair and diversion, is to do a duodenojejunostomy. Just do a Roux-en-Y duodenojejunostomy, jejunum onto the perforated area itself. If you again got control and
I read it. Thull patch repair, I guess, somewhat, huh?
Yeah.
Help actually clear. Yeah.
But
All
those
right,
are
shall we go to the
options.
next scenario?
Yeah. Yeah.
Sakib, have you got anything?
No, you can give a scenario, any scenario.
Okay. 35-year-old. Shall we? Let's keep on to the timings. I think we have to be sticking on to timings, or else we may be practicing in a way that we overrun in the scenarios always.
Yeah, yeah. No, I think today was fine. I mean, are we doing 5 minutes?
No, no, no. We'll do 5 minutes. That's more important. Okay.
That's
Sakib, I'm going to give you 15 minutes, 3 scenarios. Okay. Just
okay. That's what I wanted to know. 1 or 3. Yeah.
one. Like it will be like a consecutive scenario so that you can complete.
Okay.
Okay.
All right. Sakib, that is a 45-year-old male who comes to the emergency clinic, emergency A&E with right iliac fossa pain for the past 3 days. And he has got 2 days history of vomiting, bowels opened 1 day back. How are you going to approach? 45-year-old male, right iliac fossa pain, 3 days, vomiting. How are you going to approach?
So definitely, this is a sick patient and ended up in an emergency. This patient needs assessment and also resuscitation and management at the same point. I will do a focus history examination and will manage this patient on the line of CPS protocol. I would take the history, which includes the onset of pain, duration of pain, worsening symptoms, bowels, any recent change in bowel habits, any recent history of weight loss, any significant history of cancers in the family, any previous history of colonoscopy or biopsy in the past, any history of weight loss. In examination wise, I will see the hemodynamic stability of the patients. I will also see the I will also do the abdominal examination to see whether the patient has peritonitis or not. In the terms of management, I will give him IV fluids, will give him a shot of antibiotics, will take the blood sample for full blood count, urea and electrolytes, amylase level, LFTs, coagulation profile, and also send the urine dip as well. And based on the investigation, based on these bloods and examination finding, I will format my other rest of the
Right.
investigation.
The examination shows there is a right iliac fossa tenderness and rebound tenderness, and he has got ROF6 positive. Full blood count, his white cells are 14, CRP of 120, and rest of the bloods are normal. He's slightly tachycardic. And how are you going to approach?
So yes, so this patient looks like a septic, likely secondary to the complicated appendicitis or acute appendicitis. I will give him a shot of an antibiotics, and I would this patient might be having an acute appendicitis or might be having a diverticulitis. But as he's 45 years old, I would prefer to go with the CT scan, IV contrast, to find out the cause of right iliac fossa pain.
Okay, the CT has happened, and the CT shows there is an acute appendicitis with the findings, clinical findings, confirming it is acute appendicitis.
So this CT scan, to begin with, I made not for the to see for an appendicitis, although clinically it was evident, but also I wanted to do a cecal pole abnormality or any hidden tumor. If that is not the case, this patient should go straight away for a laparoscopic appendicectomy, and I will book and consent for a laparoscopic appendicectomy.
Okay, so you consented for laparoscopic appendicectomy, and you go in and you have a look at the appendix. It doesn't look like appendicitis. The whole of the area looks like jam-packed. What are you going to do?
Sorry, the whole of the area, the appendix looks, you are able to see the appendix or unable to see?
You're not able to see the appendix, and the whole of the area is like a mass.
Okay, so it is a very surprising finding, because generally the CT scan is very sensitive in picking up the acute appendicitis and differentiating between the phlegmon. Now the thing is that I will I will try to locally explore this area, and if there is an evidence of an abscess there, I will do a washout, and I will do a washout.
Inflammatory now. It is a mass. It doesn't look like an inflammatory.
So if it is not an inflammation, if it is it's a mass which is giving a suspicion of a malignancy contrary to the CT scan, my approach would be not. My approach will be either the two approaches I can take. I will just put in a drain, which will be my favorable approach, because I would like to take this patient back to the theater once I have a proper workup, which includes a colonoscopy, biopsy, and probably this patient might require right hemicolectomy at some point. But there is another approach which which can be taken is laparotomy, but this will not be my preferable approach. My preferable approach will be do it another time.
Okay, so this patient has got a dilated small bowel, and you think that this patient might be having some partial obstruction perioperatively. So in that scenario,
so as this patient is having an obstruction and this
these are
needs to be
completely
sorted
obstructed.
out. Yeah, and so as the patient has now presented with an obstruction and the dilated bowel with going into the plagnon, my approach would be to convert it to an open operation and try to do the right hemicolectomy and take the mass iron block and do a primary ileocolic anastomosis, ileocolic stapler anastomosis.
You have not considered right hemicolectomy. Will you proceed still?
Yeah, so because the patient has a dilated bowel, and before the operation, I will also explain that sometimes or very rarely we'll find unexpected finding in during the diagnostic laparoscopy, and if that is the case, we will do accordingly. Although and as the patient has an obstruction, it needs to be managed. And
Okay, you have not consented the patient for right hemicolectomy. Will you do it or not?
Yeah, I will prefer to do it because this patient has an obstruction secondary to the tumor, although it was not concordant with the preoperative diagnosis. But if I don't take it, then patient has a high chances of deterioration. And the best possible approach would be I will do a right hemicolectomy and we'll do an anastomosis.
Okay. You did a you opened the abdomen, you did a right hemicolectomy, and just for the completion's sake, you check the liver. There is a small nodule which has not been picked up by the CT, is seen in the right lobe of the liver. So how will be your
so after the operation, I will explain the finding to the patient that unfortunately the appendicitis was not an actual appendicitis. It was a tumor that we have taken out. And when we went in, we also found a nodule that is very suspicious that it may not be a metastatic deposit in the liver. And we will request an MRI for further delineation of this nodule. And we'll discuss this case in our MDT meeting. And we'll tell you the final plan.
So you go and say that this you had a right side of the bowel removed, and you say the patient that you have removed the right side of the colon, and the patient is shocked and he is asking you, why did you remove without his consent?
So I'll tell him that as I've explained you earlier, because even in the
no, you did not explain him. You did not explain him. The consent was not done for right hemicolectomy, but in spite of that, you did it. And now, what are you going to do?
So I would say that because the symptoms that you are having was due to this problem, there was a mass that needs to be taken out. Otherwise, these symptoms of obstruction would never have settled, and you would have required another operation straight away during this admission, maybe in next 24 to 36 hours. That's the reason why, in your best interest, we have taken this out so that the obstruction part can be sorted.
Okay, so post-operatively, you explain this, and this chap, he says that he has a past medical history of colonoscopy, colonoscopic surveillance for Lynch syndrome, and he had previous endoscopies done and polypectomies done, and he never wanted his right bowel to be removed. So what will be your approach now?
Yeah, so my approach would be I will explain the patient that this I will, of course, I will fulfill my duty of a candor, and I will say that this I know that you had this problem, but the truth is that the fact is that if we hadn't addressed this problem, your bowel might have been dilated, and that might have given complication. That might have even bursted at some point because of increased pressure in the bowel, and that was a risk was there. And we already had taken you to the full sleep, so that was the best possible thing. Now I would say that yes, for the polyps you were on surveillance. But now this time you presented with an obstruction secondary to the tumor that has to be taken out. Otherwise, it would have been a very difficult for you to live along with it. So that's the reason why I have taken.
Tell me something about Lynch syndrome.
Yeah, so the Lynch syndrome is a hereditary non-polyposis colorectal syndrome, which is due to the defect in the mismatch repair gene, and there are different types of cancers are associated with this mutation, this genetic mutation, which can be a colonic cancer, mostly on the right side, but even in the sigmoid colon cancer, you can have. There are there are different subsets of these genes, which includes MS2, MS1, MH6. These are the different genes which are involved. Sometimes the mutation of these genes can give the gastric, duodenal, and breast cancers as well. And they need surveillance, and they need to be diagnosed on an Amsterdam criteria, which is 3 to 1 mostly. However, the criteria is a bit changing nowadays, but historically it was diagnosed on 3 to 1 criteria.
What do you
And
mean criteria?
sorry,
What do you mean by 3 to 1 criteria?
3 to criteria means 3 of the family members should have been diagnosed with this problem. 2 of them should be a first degree relative, and age of a one patient at the diagnosis must be less than 50 years of age.
And
Okay.
also successive generations, no?
Yeah,
Yeah.
two. Yeah.
Okay. So what is the surveillance protocol you know about Lynch syndrome?
Yeah, the surveillance protocol of Lynch syndrome, of course, it needs a genetic testing at the first place. And if we have an instability in the mismatch repair gene, then the colonoscopy is advised 2 yearly after 25 years of age, and endoscopy is advised 2 yearly after 50 years of age.
Okay. Post-operatively, you did colectomy, and post-operatively, you do a colonoscopy after 6 weeks, and you find a polyp which was removed from the splenic flexure, which shows high-grade dysplasia.
This is a very bad scenario, unfortunate scenario, because of the likely genetic instability. This patient has a propensity to develop cancers, and as this patient has high-grade dysplasia, I would see the polypectomy specimen, whether there is an element of invasive cancer or not, whether there was a high-risk feature of cancers, which include extramucosal invasion, tumor budding, lymphovascular invasion.
No, this is high grade dysplasia. The tumor, there's nothing, no adenoma, no malignancy, no TIS.
Yeah, so then the thing is that this patient can be given an option of a surveillance, but I will do a CT scan as well, follow-up CT scan after this polypectomy. And if there is a no high risk feature, and it was Haggett 1, 2, or even a 3, this patient has a very less chance of nodal involvement with the disease, and can be offered a surveillance. But I will take this patient to MDT, and before an MDT, I will make sure that I will have a CT scan in my hand to present in an MDT and then discuss.
So this patient CT scan is done. There is a CT chest, abdomen, pelvis. As I said earlier already, there is a small nodule in the liver, which is there still. Now it is more appearing in the CT abdomen, and there is a small nodule which is there in the lung as well.
So these are likely a suspicious of metastatic deposits. Again, I need to discuss this patient in MDT. These patient required high resolution CT scan chest as well. This patient
CT scan is done. All the CT workup is done.
Yeah, so I will take yes. So metastatic isolated deposit in either liver or lung are should be offered metastectomy. That is the standard of care. But for any such deposit, I will give them first an adjuvant chemotherapy and we'll see the response. If they are still present, both of the isolated nodules can be taken out by the local resection, segmental resection for the liver, and the pulmonectomy of an involved part.
So you send the patient to the lung MDT and the liver MDT. both of the MDT said that this patient is for metastaectomy or removal of the resection of the particular segment which is involved. So, what will be your take? What will be your message to the patient now?
So my my message to the patient would, I will of course tell them the diagnosis that unfortunately, despite of our best shot, you have developed these recurrences in the stomach and the liver. But the good side of this is that the recurrences is not very much bad, and not that the burden of the disease is not too high, and we can deal with it by taking it out with the clear margins. I will need a help of a HPB surgeon and a and a thoracic surgeon for taking these deposits out. And if we do it, then I will share the data that the results have shown disease-free survival. And sorry,
He's asking you how long he'll live. He'll be living.
This is anyway, time's up, so I thought we'll just finish whatever the last
thank
part.
God time is up, because this question was very difficult. How long would I live? Thank God.
I stopped it exactly at 15 minutes. Even I was
Thank you. How much should I live? How do I know? You may die in an accident, yaar. How would I know how would you live? If I had a time, I would say that I still have no clear-cut evidence. You have already a big operation. You survived. You are going to have a big operation. You may die from the complication of it. But yes, results have shown that in comparison to the other people who don't have this, they have a good disease-free survival and overall 5-year survival. That's it.
Yeah.
Nice. Saqib, you try to tackle things in a manner. Yes, Senthil, go ahead. You are. I know that this is a tricky thing. I think you would have sensed the
Yeah.
exam.
I'm going to critique the examiner also a little bit in this case. No, I think that was obviously a very tricky scenario. Saqib, you started off well. I'm just going to go, because in order of the points I've made, I'm going to go. In history, I just wanted to know if you mentioned specifically about inflammatory bowel disease.
Yeah.
So I think with RIF, we always make it a habit to check for family history, even at 45, because any time it can present. So
exactly.
apart from bowel habits to obvious malignancy, I would say inflammatory bowel disease should be in the history. And then of course you went on to say CT scan. Yeah, I think the scenario changes quite dramatically when you have a CT that said just acute appendicitis. Unless you give more information, it's very, very unlikely for that scenario to end up being.
No, Senthil, I heard that from the people, those who appeared the exam, they said like the CT.
No, can totally happen. Yes, I think as Saqib rightly mentioned, I think it's again the matter of expression of saying that this, like you mentioned, is very unlikely in this scenario. But then, I think that's a positive point. I'm saying he mentioned clearly that this is unlikely and an unexpected finding, and that now he'll have to change his approach. I would say, Saqib, probably when he raises the point of it's not been consented, but you're doing a right hemicolectomy. So I think again you just have to reiterate that this is very unfortunate. For a straightforward appendicectomy, it would not be my practice to consent for a right hemicolectomy. But if I had any suspicion on the CT scan or preoperatively, I would consent these patients. Either a suspicion in terms of, like you mentioned, all the things, cecal growth, tumor, mass, obstruction. I would, now that I'm faced with this challenge of being in a situation where I feel the correct approach for the safety of the patient and for the outcomes of the patient is a right hemicolectomy, I would like to go ahead with the procedure. Understanding that this could be a challenging scenario in the post-operative period. The only other thing there, I don't know, I keep telling myself this, but again, depends on whether it's your special interest case or not, is to mention whether you need to consider just taking the whatever suggestion or help of a colorectal person. I will involve a second person in this case, as this is a very, very difficult scenario of a 45-year-old and who's not been consented, I would like to find out if either you can say my colorectal colleagues are around and someone
It's called safe surgery. That is called safe surgery.
Yes. So at that point, I think because you're taking the exam at a level of a junior consultant, so you may be a colorectal junior consultant who's very capable of doing a right hemicolectomy. But in this difficult scenario, where there is a problem with consent and obviously unexpected findings, I would like to confirm with the colorectal colleague if this is the right approach, or if there is, if he felt there is any other option. If two of us decided or agreed that this was the right approach for the patient, we would still go ahead. So that I think one can get you some bonus points in that situation. Two, when you come to the question of the liver nodule, I think standard of care practice is, if you do find a, say, like you mentioned, if it's a small nodule that's easily accessible in the periphery of the liver or on the surface, you are ideally either you excise a nodule or at least do a true cut biopsy since you're inside the abdomen. And one, you can say, I will assess the nodule. If he says liver lesion, you can say, if it appears like a cyst or a hemangioma or something benign, I will not, obviously assess it.
It was indeterminate lesion. That's what he said. Indeterminate
lesion. Yeah. So if it is suspicious, you are. I think it is safe to say that I will either, either you say that I'm capable of excising a small part if it's a peripheral lesion, or I will try and get, again, the liver team, if there's any HPB surgeon nearby in the operating theaters, I will try and get their opinion to get it excised, or if not, do a true cut biopsy. So you can do a biopsy of the lesion. I think that may need to be there in the approaches for the liver.
Even I didn't think of it. Actually, that's a valid point. We have to take a biopsy, isn't it?
Yes. If you're suspecting, then because it obviously changes the scenario completely, to take a true cut biopsy. The next point is when Varun mentioned about now you found a lung nodule, liver nodule. Before committing to saying metastatectomy, I think the Mddt discussion should come first, because the other things are potentially to give chemo first before going for the liver and lung.
No, the reason why I picked up is Saqib was not expecting to say. I expected him to say CT tap, CT chest, abdomen, pelvis, post-operatively. He didn't come out with the CT staging workup, so that's the reason I brought out this thing.
Yeah, and also Saqib, I think Varun mentioned liver and lung Mddt. You quite confidently mentioned that you have a solitary lesion in the lung and liver. I think it should go for a metastasectomy. So I would say that's what you should probably say, that this needs further discussion with the lung Mddt as well as the liver Mddt. And if it is agreed upon, then it is standard care practice to have these lesions excised. Either, and of course, the Mddt will involve the oncologist. Whether this patient requires chemotherapy at that point or whether surgery is the best option needs to be, discussed and obviously offered to the patient as well. So that should come, I guess, Mddt here in this case should come before you mention about ideally what happens to a
I thought Saqib will say Mddt as soon as the patient comes to the post-op ward. My first approach will be discuss the patient Mddt to safeguard yourself, as you have done a surgery which has not been consented. I will also, as Sindhil say, I will check with some other colleague immediately. I have not consented this patient for a hemicolectomy. Are you happy to come in if you are around, or do you want to proceed? Do you want to give me some opinion? Shall I proceed? Because this is like taking your partner together to do a crime.
Yeah. No, definitely. So I think it is a very challenging scenario. I think Saqib, you did very well. It's difficult. It's
true. I think these were the scenarios that probably people or the discussion went in a different direction until they give some clinical diagnosis, and they come up with a different CT approach, different CT scan with different findings, and then the discussion goes in some other direction. That's what I heard.
Yeah, it's possible. It's possible. Again, it's just, I think they're assessing our reaction to it. What is our first immediate, approach, response? Is it jumping into surgery? Is it jumping to a conclusion, or is it, just weighing all the options, discussing whether we get help, whether we mention again the expertise involved and MDT and all these things.
What do you think, Sakib? Your reply.
No, it was a good scenario. I think you must have rehearsed as well before, or you must have
No. This is I'm just talking to you
the
first.
attachment. The attachment was very coherent. It was going from appendicitis to tumor to genetics to surveillance of Lynch syndrome. It was very good made. I mean, very good made.
The reason why I picked up is, okay, I'll tell you how I went to these things. Like, I didn't prepare this scenario at all.
Or you must have seen such kind of scenario. I mean, something was
No.
the coherency was very good, and I like that part. I mean, this was
the reason why I picked up is, I'll tell you why I jumped in like this. Okay, first thing is, you started with the present illness and everything, but you didn't discuss anything about the past medical history, surgical history, and family history. As a colorectal person, these three are very, very important.
No, I asked whether you had a family history, prior history of colonoscopy, biopsy.
Oh, is it? I don't know.
Yeah,
specifically mentioned.
And bowel habits and all that. Like I said, only thing he did mention was the IBD.
IBD I missed. I remember.
And then the reason why I picked up is hemicolectomy. Whether you will do an hemicolectomy or not, is this is the issue of consenting the patient, and how are you going to discuss the consent option? I think there is definitely a scenario or a discussion about how do you consent for any kind of surgery in any patients. So this consenting process is, I think we have to make a drill of all this consenting process. And regarding the Lynch syndrome and the follow-up and all these things, do you want to add anything to this? Do you want to format things still more?
I don't think we should concentrate on the theory of it, the Lynch syndrome. That will be beyond discussion. But Sakib, for my doubt, HNPCC, I thought FAP involves duodenum more commonly than HNPCC. I think gastric, endometrium, ovary, pancreatic, but not duodenal, I think.
You're right. Yeah.
Uterine, yes.
Listen, you're right.
Yeah. I think FAP is the one that's second most common cancer in FAP, I think, is duodenal. And you have that criteria for the polyposis also,
Spiegelman criteria.
Yeah, all theory. Forget about theory. Again, Sakib, like in the approach, when he mentioned about the dysplasia in the splenic flexure, your expression was, oh, this is very unfortunate. This is very difficult. So I think but I expected that even when he spoke to you about the operation and the bowel dilatation, and at the second time when he said, the patient is saying, why did you do it and all. So again, I think you would just practice expressing that, this is a very, very difficult scenario. And obviously it's a very difficult decision that we made in theater. I would explain to the patient that we are not in the habit of doing an unexpected operation without consent unless it is life-saving or limb-saving, or we feel that it is the standard of care. So it is very difficult. And even at that point, whether you want to, like he said, I think involve your colleague or all those things just to back up what you got.
Sakib, and I think the general crux here in this scenario is we can include one of the colleague in difficult situation so that you can back up things during the post-op conversation, that it is not only my decision. I had another opinion with my colleague, and he is also of my opinion. So we went ahead together. So it's a valid point, and it's a valid approach. You have someone to back up yourself as well. And regarding post-op, I don't know whether you know about this thing or not. I feel like if any patient who comes after the surgery, any emergency surgery, do you put the patient on the MDT immediately, or you take some time? I don't know. What is your practice in?
So mostly it's on the clinical findings. If it's a very high risk for a cancer, then this patient should have an even post-operative CT thorax as well. At the same time, even on a fourth, fifth day, we always do that, and we put them on MDT as well.
So it is your practice, isn't it? Like immediate
Even
post-op.
even we get a CT thorax as well. Straight
chest
third, fourth day.
abdo-pelvis.
CT tab,
CT abdomen pelvis you have already done now because of the
No, chest abdo-pelvis.
Yeah. So CT abdomen pelvis you have already done because of the right electrosa pain. They always go for a CT chest in our hospital on a third, fourth day for the completion of a workup, and then they are put in the MDT.
Tell me something more about Mddt discussion. If supposedly this patient is discussed in Mddt immediate post-op, what will you as a consultant, what will you discuss in the Mddt? Just out of like this is just a scenario.
Yeah, I will definitely would like to know what is the type of a tumor, what is the grade of a tumor, are there what is the how many lymph nodes are involved, what are
no, I'm sorry to stop you here. So you had a different scenario. Your report is appendicitis. You went in and you saw a mass and it looks like a obstructive cecal tumor or right-sided tumor. What will you discuss now for this scenario in the MDT?
No, in this I couldn't get your question. Sorry. What was the question?
No, I'm saying you had a different scenario intraoperative and your report is different. You had a different pathology intraoperative. So what will you be discussing in the MDT? Will you discuss that this patient had a CT report saying appendicitis, I went in, I had a tumor?
No, yeah, I'll say that I'm a surgeon who performed.
I think the CT will be rediscussed in the MDT if there's a discrepancy.
Yeah. So
that is what I'm asking. That is what I'm asking.
Yeah. So what I would say that yes, I'm a surgeon who performed this operation with a preoperative diagnosis of an acute appendicitis, and the operation had to be converted into a laparotomy and a formal right hemicolectomy with an oncological resection. I wonder, can we repeat the CT images, please, so that we can see was there any suspicion of a tumor or cancer or not. So that's how I will take it.
Actually, I wanted to go into that scenario rather than going into lung meds and all these things, because I thought you will take me to that way. When you're talking, I thought you will take me to that way. So what other things you will ask the pathologist just for your exam sake? No.
Yeah, from the histopathology, I would ask the type of tumor, grade of tumor, whether the lymphovascular invasion is present or not, how many lymph nodes are involved, whether I have safely taken out 12 lymph nodes or not. I would also see the margin, deep margins, proximal circumferential resection margin, proximal margin, distal margin.
So you have done the right hemicolectomy. So margins are clear, nodes, 4 nodes positive, high tie with clear, no nodes in the high tie. Rest of the things are normal.
Yeah, then this patient, she needs adjuvant chemotherapy, and I will discuss with the oncologist. Then I will refer this patient to oncologist.
Anything, any particular test do you want to do?
You means the genetic testing. This was 45 years old. Yeah.
Okay. Anything else? What regimen you will think of?
Regimen.
Okay, if at all this patient goes for chemotherapy, adjuvant chemotherapy, what regimen you will give?
FOLFOX.
FOLFOX. Do you want to do any blood test before FOLFOX?
CEA levels.
CEA levels, okay. CEA levels is not
for the chemo, I think.
DPYD.
DPOID, that is for the FOLFOX level. For
this is for oncology special interest. Varun.
No. This is commonly discussed in MDT.
I know. It's in our every MDT. It's the same.
DPOID. Yeah, that is for getting 8 marks. I am sitting for 6 marks. I am not sitting for 8 marks.
Gold medal question for surgeon.
No. It is purely colorectal.
DPOID.
No. Even in our HPB, because of the liver mets, they all receive the. Anyway, can I just comment on a point?
It is said that Sorry to interrupt. It is said that that even in your specialty, you have to know inside out of the disease. I think it is not possible that at my 8 years of experience, I know each and everything about colorectal. It is next to impossible. Like a Crohn's disease. If we take just a Crohn's
No,
disease,
I
people
think
have
that
developed a
question will
fellowships
be
in Crohn's
extra
disease.
marks. It's not going to be
Yeah.
deciding your pass or
People
fail.
have developed even today I was thinking about it, that if I get a Crohn's disease scenario, whether they will be asking me about these new form drugs which even hard to pronounce as
That's if
well.
you've already passed.
Oxtibimab, Uxtacumab, will they ask me? So I
Anyway,
think,
Zakib, coming back to the scenario,
yeah.
just tell me your opinion on this. When Varun, say, asked you the second time about, say, you said you will do a right hemicolectomy because there was small bowel dilatation and you gave your reasons. The second time again, he asked you, but this patient is not consented, will you still go ahead? Tell me if how you feel about this. But in my answer would have been, obviously this is very difficult situation and it's a very difficult decision to make. I would have to weigh the pros and cons of just closing the abdomen now, coming out, because there is no peritonitis. Assuming there is no peritonitis, you've done the damage control part, you've seen a mass. I would say it is very difficult. One situation would be if I just close the patient, and of course, once the patient wakes up, I will have to continue to manage the bowel obstruction as much as I can conservatively, while explaining to the patient the scenario and the possible need for a re-exploration laparotomy. And if the patient does stabilize in that scenario, I can do a staging CT scan and proceed. Versus the cons of doing obviously a right hemicolectomy at this scenario, which may improve his outcomes, which may give a definitive solution to the problem at the cost of facing resistance from the patient because consent was not done, and if, say, suppose there was a role for conservative management. So just whether, in the off chance we are encountering this scenario again, whether that is possible, because you've done a diaglap, you've not explored, you've done a diaglap, you found a tumor, and you can go out, you can come back next day and do right hemicolectomy with consent.
Just a discussion. I think a valid point, Sandil. I think the options in that we can. I think we can start with saying that the options right now. I think he said the options are just put it right and come out, and the second option is go and do it. But the other option is, like, the third option is get a colleague involved if I'm going to do it.
Of course, yeah.
Colleague involved, and
That is the best option. That is the best option.
yeah. And the third thing is
Best option.
yeah. So the third thing is, once if it is done, we can argue in a way that you don't need another anesthesia, another surgery. So the definitive procedure right now is done, and there won't be any more, no more abstraction features or anything. It is more of like 50% of the job is done in terms of surgical problems.
Yeah. Okay.
Right. Nice. Shall we go ahead and wind up, or?
I think I'm going to have to sign off today, guys.
Okay.
Yeah, but when we are coming back, are we coming back tomorrow?
I'm out for the next 2 days for sure.
Yeah, Sendil was saying that he's not here.
Monday
evening is okay because I'm post nights.
I'm on nights Monday. Yeah, I'm on nights. I start at 8, so yeah.
I'm also post nights. We are all having nights on Platinum Jubilee, huh?
I'll be starting my nights, so I'll be okay on Monday, Tuesday.
Okay, you'll be starting nights on Monday.
I'll be starting Monday.
So what we can do for Sentil, Varun, we can make it more early, maybe at 4 o'clock, so that 5 o'clock, so that he can. Huh?
Tell me, no problem. Can we have one session with Prashant and Gwen?
Yeah, definitely.
Yeah, so I think Varun, I think that we should have a session with Prashant and Varun at 2 different points. One is that I have no hesitation to sit with them at this moment now, where they can just tell me what was their experience, what was the expectation of the examiner, and how the show was actually run. involving them as an examiner is at that point, I think, is not a good idea. What I would say that first we practice ourselves on all the scenarios, and when we reach at that level, when we can just extemporally speak on any topic, then call them maybe in July, and then
they'll forget all the questions. You have to get all the questions.
No. Like Saqib says, this time when we speak to them, let them just tell us whatever scenarios they remember, whatever they went through, how was the special interest cases, how was the special, let them just tell us that before they forget. But then to actually have a session where they do the questioning and examining, he feels it'll let it be a little late.
Do that. When can we do that? Saturday, Sunday.
And Santil, have you booked me and Varun have booked the Alpine course? Have you booked the Alpine course?
Yes, all three will be meeting there in Alpine.
Yeah, so that's a good point. And before the Alpine course, we have to give at least 1 or 2 sessions for an academic viva as well, because the rest of the things we are all familiar, more or less. We can speak on any topic.
When
but
can we
the
do
academic part is the one that at least maybe somewhere around 22 of this month before the course, if we can have a one sitting on the academic part as well, right?
Sure.
So Monday 5 o'clock, right? Thank you.
Okay, Sandeep. Thank you. Thank you all. Monday 5 o'clock.
Monday 5 o'clock. Thank you.
Thank you. Bye.